So what I was going to talk about is MDS treatments and some newer developments that are on the horizon. And these are my disclosures. So what I was going to present is a bit of background information really, and to talk about a bit about risk-modified treatment strategies based on whether you're lower risk by IPSS score or higher risk by IPSS score, and then what's available for patients that have failed hypomethylating agents. Okay, so myelodysplastic syndrome is a disease of older people, and what you're going to notice is that there's a five-fold difference between the incidence of MDS when you're between the age of 60 to 69 years as opposed to when you're 80 years and older. And you know, with the population getting older and people living longer, you're going to see a lot more incidences of myelodysplastic syndrome with time. So to try to help prognosticate patients and to help with making decisions about treatment options that are available, there's been a number of different prognostic scoring systems that have been created over the course of time. The most common being the IPSS score, or the International Prognostic Scoring System, and it's been since been modified since about 2012 by a revised IPSS score. But most of the treatments that are available and that have been approved by the FDA or Health Canada are based on IPSS criteria. So the IPSS score is based on three different variables, and it's really percentage of blasts in the bone marrow, the cytogenetics that you have, and also the number of cytopenias, whether you're anemic, thrombocytopenic, or neutropenic. And it's really based on a composite scoring system. So you add those three variables together and you come up with a score. So you're either low risk, intermediate 1 risk, intermediate 2 risk, or high risk, okay? And there's different sort of prognosis associated with it. So if you're lower risk, your median survival is about 5.7 years. If you're a higher risk, it's under 1 year, okay? And it also tells you the risk of progressing to an acute myeloid leukemia. However, the scoring system is not as sensitive because it doesn't take into account the type of cytogenetic abnormalities that are really out there. There's a huge number, and it doesn't really stratify based on that. It overweights the percentage of blasts as opposed to the cytogenetics, and it also doesn't take into account the degree of cytopenias that people have. So this was modified with the IPSS scoring system. So the other thing is that most people think that if you have an MDS, you're going to progress and die from acute myeloid leukemia, but the reality is it's only overall about 30% of patients that progress to AML. The majority of patients will die from complications of the cytopenias, or else from other comorbidities or medical illnesses that they have. So going into the IPSS-R scoring system, over 5,000 patients have been evaluated for their cytogenetic abnormalities or chromosomal abnormalities. And the cytogenetic scoring system was modified to come up with 5 different groups. Whether it's very good cytogenetics, like if you had a deletion 11q or you had a loss of chromosome Y, versus very poor risk where you had greater than 3 abnormalities. And what you're going to see is that the risk categories actually correlate with overall survival. If you had a very good risk category, your median overall survival was 61 months versus if you had a very poor risk cytogenetics and it was only 6 months. So this was incorporated into the revised IPSS scoring system. And again, it's based on cytogenetics, the percentage of bone marrow blasts that are available. Also, the degree of anemia you have, whether your hemoglobin's 100 or higher, or else it's 80 or less. The degree of neutropenia that you have, as well as the degree of thrombocytopenia. So all the variables are added up, and again, you get a composite scoring system, so you could be one of 5 risk groups, either very low risk to anywhere to very high risk, okay? And once again, this correlates with overall survival and likelihood of transforming to acute myeloid leukemia. So if you're very low risk, your median overall survival is about 8 years, 8.8 years. Less likely to progress to AML based on the time that they follow these patients. But if you were very high risk, your survival is still under 1 year, and you're more likely to progress to an acute myeloid leukemia. So really, using the scoring systems and based on your World Health Organization classification, Treatments are really based on age, the functional status, other medical conditions. And really for lower risk patients, you try to improve the counts or decrease the disease-related complications, and you improve the quality of life. Whereas people that have higher risk disease, you're trying to change the natural history of the disease, either to improve overall survival, delay leukemic transformation, or potentially cure the patients depending on what age they are. So what I was going to go through was some of the treatments that are available for patients that have lower risk myelodysplastic syndrome, and some of the studies that are coming through to try to see if there's any potential benefit with newer drugs. So what we know for the main part of treatment, about the majority of patients will present with anemia. And one of the treatments that have been available for a long time is really erythropoietin stimulating agents, or EPREX or darbepoetin. And these drugs work by increasing or stimulating the early stage erythroid precursor. So you actually get more of these red cells around. And we know that, however, it only works for a proportion of patients, maybe upwards to about 20 to 40% of the patients. And usually it's an expensive drug. So the Nordic group has come up with a decision model to try to calculate who is more likely to benefit from erythropoietin versus not benefit. And it was really based on serum erythropoietin levels, as well as your transfusion requirements. So if you had an EPO level of less than 500 and you were getting less than 2 units of packed red blood cells per month, the likelihood of responding to ESAs was about 74%. However, you required more transfusions than 2 units a month, and your EPO level was greater than 500, likelihood of responding was 7%. So that would not be cost effective to probably administer the drug. However, in Ontario, the only way you can really get ESAs approved is really if you have a documented EPO level of less than 500, and the government will approve it for at least a 3-month period, and you have to document response to get ongoing coverage. A newer group of drugs that are currently under investigations are called activin receptor antagonists, and they're really traps for the ligands of the TGF-beta signaling pathway. And these work differently compared to ESAs. They actually work at a later stage of erythroid development, and what they do is try to stimulate the differentiation and the maturation of the erythrocytes. So at the American Society of Hematology last year, there were 2 different drugs that belong to this group of drugs that were presented at the meeting. One of them I'm just going to talk about is luspatercept, or ACE-539. And it was a phase 2 study that was performed in patients with low intermediate 1 risk myelodysplastic syndrome. And to be eligible for the study, you either had to have an EPO level of greater than 500, or else you could not have responded to or lost a response to ESAs. And you couldn't have received any prior hypomethylating agents, no lenalidomide currently, ESAs, or G-CSF. And really, the drug was administered as a subcutaneous injection every 3 weeks for 3 months. So you got 5 injections over a 3-month period, and then you were followed up. Okay. And a bunch of different doses were evaluated. And what they saw on the box, I guess in blue, when they administered doses of like 0.75 to 1.5 milligrams per kilogram, they saw an overall response rate of about 41%. And on the column on the right, LTB means just low transfusion burden, meaning they were receiving less than 4 units of packed red blood cells over an 8-week period. HTB means high transfusion burden, meaning they were receiving more than 4 units over an 8-week period. And you saw responses, meaning hematological improvements with either an increase in the hemoglobin that lasted for greater than 8 weeks if you were low transfusion burden, or if you were a high transfusion burden, they actually saw a decrease in the number of red cells you got transfused over an 8-week period. So they also tried to see if there were any features clinically and also by a somatic mutational analysis to determine whether you were likely to present patients that were more likely to respond to the drug. And what they saw for all 17 patients that responded, if you had a presence of ring sideroblasts, that's what RS stands for, your likelihood of responding was 54%. They also looked at the mutations in the splicing factor, SF3B1, and that was present in about 9 out of the 17 patients. All of these patients had ring sideroblasts. Likelihood of responding was 67%. However, 1 out of the 8 patients that didn't have that mutation had also responded. So what's happened now is that I guess the drug is going to be going into phase 3 development. It's going to be drug versus placebo for patients that have IPSS-R, so that's revised IPSS score, very low or intermediate risk. And the patients have to have ring sideroblasts because that was one of the markers of response, and they also have to be red blood cell transfusion dependent. Okay, so the drug is not available right now except as part of a clinical trial, and then I guess time will tell whether there is any efficacy compared to placebo. So the other drug that's been available for patients with lower risk myelodysplastic syndrome is really lenalidomide, and we know this got approved a while ago for deletion 5q abnormalities in lower risk patients. And so this is just what chromosomal analysis looks like in a patient with a deletion 5q abnormality. With the arrow, you're going to see a deletion of the long arm of chromosome 5. And we know that about 20% of patients actually have abnormalities in chromosome 5, either loss of chromosome 5 completely or else some deletion, and usually involving the 5q region. So this is the phase 3 study that led to the approval both in Canada and in the States for lenalidomide in deletion 5q patients. And it was really 148 patients that were treated either continuously with lenalidomide or with lenalidomide 21 out of 28 days. And what you're going to see is that 67% of the patients actually became transfusion independent, and 36% got a complete remission with no signs of disease in their marrow. And time to response was just under 5 weeks. At the time the study was presented, there was over 2 years, they still hadn't found a median response duration. Subsequently, follow-up was presented at the EHA meeting in 2008, and this was after a follow-up of 3.1 years. And what you're going to notice is the median duration of the response for people that received lenalidomide who had a deletion 5q abnormality and lower risk MDS was 2.2 years. And longer if you just had an isolated deletion 5q abnormality, meaning no other chromosome abnormality, and shorter at 2 years if you had deletion 5q plus some other abnormality. Lenalidomide has also been looked at patients with lower risk MDS who don't have that deletion 5q abnormality, so they could have had just normal cytogenetics or some other abnormality. And the results of a phase 3 trial comparing lenalidomide to placebo was presented at the ASH meeting last year in 2014. And it was really 239 patients that were randomized to either receive lenalidomide 10 milligrams daily or placebo. And they had to have low or intermediate 1 risk myelodysplastic syndrome. They could not have a deletion 5q abnormality, but they could have any other abnormality or no abnormality. They could not be responsive to ESAs or had an EPO level greater than 500, and they had to be red cell transfusion dependent. And really, the outcome of the study was really to look at the number of patients that became transfusion independent and to also see if they could have a gene signature that would correlate with telling patients who are likely to have a response or not. So what you're going to see is a table showing the responses that were observed in people that received lenalidomide versus placebo. And you're going to see about 27% of patients actually became transfusion independent, so meaning they didn't require any transfusions for 8 weeks or greater. And the duration of the response was 8.2 months, okay? The follow-up was not long enough to look at median overall survival. So from this study, we know that the response rate is not as high as for deletion 5q MDS patients, and it's not as durable. However, there is some response, and it may be of benefits for a certain group of patients that don't have any other options available to them, because once you fail ESAs and you have lower risk myelodysplastic syndrome, there's nothing else that's currently available for that group of patients. Okay, so that may be something to consider. The only thing is that in Canada, Celgene has not sought to get that license yet. I think they're trying to get further information, and it's the same thing for the UK, or in the US, it's available, so everybody uses it off-label anyways, okay? But you may be able to get it on compassionate basis from Celgene, so you would just have to speak to your physician about that. So right now, the recommendations for lenalidomide is really for lower risk myelodysplastic syndrome based on IPSS score. And they have to have a deletion 5q31 abnormality. And you could probably start with a dose of 10 milligrams, but you're going to have to dose reduce it because everybody gets myelosuppressed within the first 8 weeks of treatment. And then there is some benefit, but it's limited in people that have low risk MDS that are transfusion dependent, but they don't have that deletion 5q abnormality. But it may be beneficial for a certain group of patients. So the other thing that's come along is looking at hypomethylating agents. So it's either azacitidine or decitabine in patients with lower risk myelodysplastic syndrome. So currently none of these drugs are approved in Canada for lower risk myelodysplastic syndromes. But there's been some interest in looking at this really with an oral formulation of azacitidine for patients with lower risk myelodysplastic syndrome. And Dr. Garcia-Manero from MD Anderson had presented some data at ASH 2012 showing that 53 patients who were red cell transfusion dependent, or else they had platelets less than 50, who were treated with oral azacitidine for 14 days out of 28 days or 21 days out of 28 days. There was some sort of benefit. Median age of the patients were older, so they were in their 70s on the most part. They were either transfusion dependent or else they had a low platelet count of less than or equal to 50. And what you're going to see is that whether you got the 14-day or the 21-day schedule, you had a benefit. They had an overall response for the whole group of patients of about 34%, sorry. But you're going to notice for the 21-day out of 28 days, 60% of the patients actually had a complete remission in the marrow. So what's happened is because of the interest in getting hematological improvements and also potential for marrow remissions, the study, the drug has been taken forward and is currently ongoing. A phase 3 trial of oral azacitidine given for 21 days out of 28 days compared to placebo for 21 out of 28 days. And it's really for patients that have lower risk de novo MDS, that are red cell transfusion dependent, that have platelet counts of less than or equal to 75, and they've never had received any prior azacitidine subcutaneously or decitabine subcutaneously. And the goal is really to look at what proportion of patients become transfusion independent. So that study's ongoing, and I think it's been slightly difficult to recruit the patients onto this study just because there's not a lot of patients with lower risk MDS that have low enough platelet counts, that's the thing. So with respect to the higher risk myelodysplastic syndromes, I think one of the known or standard or treatments since about 2009 has been hypomethylating agents in patients with higher risk MDS. And this is the phase 3 study that got azacitidine actually approved in Canada and the UK. Azacitidine was approved in the States since about 2004. But this is the study that got it approved because it showed the survival benefits. So over 300 patients were randomized to either azacitidine or one of the conventional care regimens. So the physicians would choose either best supportive care, low-dose Ara-C, or intensive chemotherapy versus azacitidine, and patients got randomized to the respective arm. And really, you continue treatment with azacitidine or the conventional care regimen until toxicity or disease transformation. And the primary outcome was to look at overall survival. And what you're going to notice is that the table shows the response rates for patients who received azacitidine compared to those that received conventional care regimens, either best supportive care, intensive chemotherapy, or low-dose cytarabine. And you're going to see response rates were only about 17% complete responses in azacitidine versus 8% in conventional care regimen. So the responses were not high at all. And it was really, even after administering 6 cycles, 81% of patients got their first response, and then 90% got it by 9 cycles of therapy. But the responses were not high at all. Surprisingly enough, when you look at the overall survival, despite not having a high complete remission rate, 2-year overall survival was about 51% for patients who received azacitidine, compared to only 26% that received either low-dose IRC, best supportive care, or intensive chemotherapy. So the survival is what led to the approval of the drug by Health Canada and also in the UK. So what you're going to do, they subsequently presented some subgroup analysis, and what you're going to see is, I mentioned before, that the complete remission rate was quite low, but the survival benefit was seen in anybody who had either stable disease, some sort of hematological improvement, either their red cells, neutrophils, or platelets, or else if they achieved a partial response or complete response. So this was the first drug, and everybody keeps saying that showed the survival benefit without actually having to get rid of all signs of the disease. And that's probably unique to this group of drugs as opposed to any other group of drugs that we've seen. The other thing is, besides prolonging overall survival, azacitidine has been shown to prolong the time to developing acute myeloid leukemia. Remember, for the higher risk group of patients by IPSS criteria, most people will either die with like median survival of about a year or slightly under a year, but also a good proportion will progress to AML. And what you see is that with conventional care regimens, the median time to progressing to AML is about 12 months, but if you received azacitidine, that pretty much doubled it to about 26 months. So there's a benefit to using azacitidine, not just for survival, but also for prolongation of the time to developing acute myeloid leukemia. And this is just to show you that 45% of the patients achieved red cell transfusion independency. And really well tolerated, even though we call it a chemo drug for lack of better terminology. Really, you get cytopenias, but really during the first 2 cycles of therapy, and then it sort of goes back up to your baseline by the 3rd cycle. Nausea and vomiting, which is controllable with anti-nausea medication. Injection site reactions, really redness, bumps, some bruising, and constipation, but really from the anti-nausea medication that we give as opposed to azacitidine itself. And this is just to show that people do get cytopenic, so your counts are going to get worse with the first 2 cycles of therapy. You may need more transfusions during that time, but by the 3rd cycle, it usually goes up to your baseline. And even though your counts are low, you don't end up in hospital more often at all. So the other thing was looking at combination therapies. So there's a whole bunch of studies looking at different combinations with azacitidine, and what I'm just going to present is some of the earlier studies, and that were done. So there was a bunch of different studies done in combination with azacitidine, which had shown that they got a higher complete remission rate, anywhere from 40 to about 50%, and the time to achieving that response was under the 6-month time that was seen with single agents azacitidine. So the intergroup, SWOG, actually performed a phase 2 randomized trial comparing azacitidine to azacitidine plus lenalidomide, or else azacitidine plus Vorinostat. So about 90-odd patients were randomized to all 3 arms, and it was really for higher risk, intermediate to or high risk MDS, but they did allow some exceptions if they had greater than 5% blast. They could not have any prior hypomethylating agents, so no decitabine, no azacitidine. They could not have received any histone deacetylase inhibitors such as Vorinostat or others, or lenalidomide. And it was really to continue treatment until they developed toxicities or had disease progression. And primary outcome was really response rate, overall survival, and toxicities. So again, the data was presented at the American Society of Hematology meeting in 2014. And unfortunately, when you look at the overall response for the 3 different arms, azacitidine versus Aza plus lenalidomide versus Aza plus Vorinostat, there was really no difference in overall response rate. The CR rates were completely the same. It wasn't statistically significant at all, for an overall response of 33% and a CR rate of still about 19%. So it wasn't higher, even though the phase 2 studies had suggested that you got higher response rates with the combination. And when they also looked at relapse-free survival, so meaning no signs or recurrence of the disease if you had a response, it was only about 7 months, so there was no significant difference. The initial thing was they were going to take it further to a phase 3 development if any of the results panned out, but it hasn't panned out, so that's not going to be developed any further. So the other thing I was just going to mention briefly was that, since the majority of patients with higher risk myelodysplastic syndrome are treated with azacitidine if they're not transplanted, what to do when patients fail therapy. So what we'll notice is that Prabot and then presented some data suggesting that over 300 patients that failed therapy with azacitidine had a median overall survival of 5.6 months. And when we looked at 2 years, it was only 15%. And nothing seemed to improve overall survival except potentially investigational therapy and allogeneic stem cell transplant. And the caveat with the transplant is that there were younger patients that went on to transplant and they hadn't been as heavily treated. So there's been an interest in trying to develop treatment for that group of patients. And really one of the studies that were presented at the ASH meeting in 2014 was Rigosertib, which is a small molecule inhibitor against a bunch of different kinases, including polo-like kinase, PI3 kinase, and AKT. And so this was a phase 3 study that was developed again based on phase 1, phase 2 data that suggested that you could improve survival by up to about 11 to 12 months if you gave this drug in patients that failed prior hypomethylating agents. And patients were randomized, about 299, randomized to either Rigosertib or else best supportive care. And they had to have failed azacitidine or decitabine. And they also had to have either some sort of cytopenia, and the primary outcome was to look at overall survival. Unfortunately, when they looked at overall survival, there was no difference between the two arms, so Rigosertib did not show any survival benefit compared to just giving them best supportive care. But then when they did a subgroup analysis, it looked like people that were under the age of 75 who had either primary resistance to hypomethylating agents or else who had received hypomethylating agents for less than 9 months or had a very high IPSS-R score had some sort of survival benefit. So what the company is doing is they're taking it forward as a phase 3 study in that group of patients to develop it specifically to see if there's any benefit in hypomethylating agents that are had received it for less than 9 months, very high IPSS-R score.